Good afternoon, everyone. I'm Ellen Lautenberg, a board member at the Institute for Climate Change, Environmental Health, and Exposomics. I've had the privilege of being involved with Mount Sinai's groundbreaking environmental health work for over a decade. Today, we're addressing an urgent issue that sits at the intersection of two critical public health challenges: our changing environment and stroke risk. The global rise in stroke incidence among young adults is alarming. While this is often attributed to traditional risk factors like hypertension, diabetes, obesity, high cholesterol, environmental factors must also play a role. In fact, it was nearly 20 years ago that the American Heart Association published its first statement linking exposure to particulate matter, air pollution, with cardiovascular disease and stroke. Today, we'll hear about the incredible advances made in this area, particularly by Dr. Yitshak-Sade. Mount Sinai has long been a leader in exploring how environmental factors impact health across the lifespan. With Exposomics, a field studying lifetime environmental exposures and their biological impacts, driving remarkable progress. Utilizing tools like satellite data, wearable sensors, and innovative lab methods, researchers are uncovering links between exposures such as air pollution, heat, noise, and chemicals with disease risks, including stroke. The Institute is also fostering collaboration between clinicians and environmental researchers, ensuring cutting-edge findings translate seamlessly into clinical practice for direct patient benefit. Understanding how these exposures interact with nutrition, lifestyle, and social determinants of health will allow scientists to paint a clearer picture of what drives stroke risk, and most importantly, how we can work toward prevention. I am thrilled to introduce our speakers who bring their expertise to this vital topic. Dr. Maayan Yitshak-Sade, an environmental epidemiologist whose research focuses on how air pollution and heat exposure affect cardiovascular health, and Dr. Ismail Nabeel, a clinician and researcher specializing in occupational and environmental medicine and the use of artificial intelligence to understand public health risks. Please join me in welcoming them to the stage. And Dr. Yitshak-Sade, please go ahead.
Thank you. I'll just share my presentation for a second. Okay. Good afternoon, everyone, and thank you so much for the introduction. My name is Maayan. I'm an environmental epidemiologist, and I study mostly how climate and air pollution affect our risk for developing cardiovascular diseases like strokes and heart attacks and premature mortality. And today I wanted to focus about stroke, specifically about the missing piece in stroke risk, which are environmental factors. I wanted to start by explaining in very general terms what stroke is. So we can split stroke into two large categories: ischemic stroke and hemorrhagic stroke, where in ischemic stroke, the blood flow to parts of the brain is blocked or reduced, cutting off oxygen, and then nutrients that are needed for brain tissue to survive can't reach these areas, which causes brain cells to die and can end with death and severe disability. The other type, hemorrhagic stroke, happens when a blood vessel in the brain bursts or leaks, leading to bleeding in the brain, and then the buildup of blood creates pressure on the brain, causing damage, and also can end with death and severe disability. So this is a major and severe disease that needs our research attention. Beyond this severity, why is it a major public health concern? Because it is very common in the US and globally. It is the cardiovascular diseases in general are the #1 killers in the United States. Just to show how common this disease is, every 1 in 6 deaths from cardiovascular diseases in the US is due to stroke. Every 40 seconds, someone in the US has a stroke. And every 3 minutes, someone dies of stroke. So you can see by these numbers that it is very common and needs our attention. Now, the good news is that many of the etiologies for this disease are modifiable, which means that there is something that we can do to try and reduce the burden of this disease. And I wanted to also mention that although the stroke rates have been declining in the US in recent decades, there is an alarming trend of increasing risks in young adults, and we try to understand why we see this shift in trend specifically among young individuals. Now, if I tell you to consider your risk of developing stroke or cardiovascular disease, I'm sure you'll think about these traditional risk factors, which we all know, right? High blood pressure, cholesterol, glucose, whether you're smoking or not. And there are, in fact, online tools that you can use and try to predict your risk of having an acute cardiovascular event or death in the next 10 years or so. So, for example, if a very healthy individual tries to fill out these online tools, and they'll fill out their age and sex, whether they're smoking or not, their cholesterol levels, their blood pressure, if they're taking medications to reduce blood pressure or not. So if you're in an excellent shape, your score will be 0%, which means that there's a zero chance for you to have a stroke or heart attack within the next 10 years, which is, of course, excellent. However, it doesn't take into account all the environmental exposures that you are exposed to, right? It only takes these traditional risk factors, which includes the clinical risk factors, the diseases that you may have, and the behavioral risk factors. But we know in recent decades of research, from recent decades of research, that many features of the environment also affect your cardiovascular risk. And today I wanted to focus on 3 of these exposures: air pollution, temperature, and greenness. I also wanted to mention in this slide that there are other exposures that we know that can be associated with increased risks for cardiovascular diseases or metabolic diseases like diabetes. And I added noise here as an example, even though I won't focus on noise today. So starting with air pollution, which is a major environmental risk factor for cardiovascular disease. Air pollution accounts for 7 million deaths annually. And in fact, most of the world population is exposed to non-healthy air pollution. It is ranked at the top risk factors for global mortality. It is the 4th risk factor for global mortality. And if we focus specifically on cardiovascular health, every 1 in 5 cardiovascular deaths is attributable to air pollution. So this is to show that it is a very serious risk factor, especially in light of the fact that we all breathe the air. So we all are exposed to unhealthy levels of pollution in some days, if not all. We don't know exactly how air pollution causes cardiovascular disease. The most common assumption is that these fine particles that are inhaled through the lungs can be transferred to different systems in the body because they are so small. Then they induce different processes like inflammation that accelerate the development of risk factors for developing cardiovascular disease like diabetes, hypertension, which then in turn can cause acute cardiovascular events like stroke or heart attacks. It can also cause chronic cardiovascular diseases like acute coronary syndrome and can end even in mortality. Now, in recent decades, most of the research was focused in PM2.5, which are these inhalable particles, and these are measured by their size. So the research basically looked at the concentration of these particles and how this is associated with risk. However, this approach doesn't capture the different composition that these particles may have. It is very important because air pollution can arrive from different sources. And we know that not all sources are dangerous in the same manner, right? Some sources can be riskier than others. And with the developments that we achieved in recent years, we can now assess the composition of these particles. And I'll show an example in a minute where we focused on the different sources. But before I get to that, I just wanted to mention some common air pollution sources in the US. So this particular air pollution in our country can come from industrial pollution, from more natural dust and agriculture. It can come from traffic, wildfire smoke, and of course, oil, coal combustion, biomass burning, and also salt particles in these coastal areas that also contribute to particulate pollution. In the US, the national annual standard for PM 2.5 is, until a couple of years ago, was 12 micrograms per cubic meter, which means that all states need to make sure that their emissions do not exceed this threshold. But then a couple of years ago, the World Health Organization conducted a very thorough research, including many of our studies, which showed that air pollution levels in exposure in levels that were lower than the national standards were still associated with higher risk of dying and higher risk of developing cardiovascular disease. So they conducted this thorough research, and then they came up with a recommendation that the standard should be way lower than 12 micrograms per cubic meter. And they say that in order to protect human health and the environment, standards should be set to 5 micrograms per cubic meter. A couple of years ago, the EPA indeed updated the standard in the US, but they lowered it to 9, which is still significantly higher than the threshold that is recommended by the World Health Organization. And then finally, I just wanted to show that it is very important to consider different geographic areas when we think about air pollution, because it differs geographically quite a lot. In the map here, you can see that in some states, the mean PM 2.5 levels are very low compared to other states where the exposure levels are very high. And this is just adds more to this point where air pollution differs by geographic area and by source. Now, how can we assess the effect of air pollution on stroke risk? We use satellite images and machine learning approaches to estimate daily air pollution exposure in relevant addresses. I say we, but it's not really me, it's my colleagues who build these models. And they're able to historically estimate daily levels of exposure, of air pollution exposure to which people were exposed to going back 25 years. We then link this state-of-the-art exposure model to city, state, or nationwide health data and ask the question whether people who are exposed to higher pollution levels are at higher risk of developing or dying from stroke. And an example for a recent study where we use these models is a study that in which we included about 70 million Medicare beneficiaries across the United States. And in this study, we wanted to see whether air pollution exposure from different sources is associated with higher risk of dying due to atherosclerotic cardiovascular disease, which includes death due to ischemic heart disease or stroke. Using these exposure models, we were able to, in each address, to estimate exposure to different components of air pollution and then attribute air pollution to specific sources. So we use these models to simultaneously investigate whether exposure to air pollution that originates from oil combustion, soil and dust, industrial pollution, biomass burning and coal burning, or traffic is associated with high risk of dying due to ischemic heart disease or stroke. Now, overall, we found a 4 to 6% increase in the risk of dying due to these diseases that was associated with higher air pollution exposure. But I think that the important message of this study is that the risks differ depending on the source and the geographic region. For example, in the Northeast, in our area, the most important source, or the source that was associated with the highest mortality risk, was oil combustion. However, in the West, we found that biomass burning and coal burning had the strongest association with atherosclerotic cardiovascular disease mortality. And in this study, another important point is that even when we restricted the population only to those who were exposed to levels that were considered safe by the EPA, meaning lower than 9 micrograms per cubic meter, we still found a significantly increased risk of dying due to atherosclerotic cardiovascular disease which means that this threshold is not enough to protect cardiovascular health. The second exposure that I wanted to discuss today is temperature. Global warming, as you know, is one of the most pressing consequences of climate change. And with global warming, extreme heat and cold are expected to become more frequent and severe. Now, hypothetically, heat can be associated with high risk of stroke, and it relates to sweating, dilating blood vessels, dehydration, which can then decrease the blood flow to the brain. So we wanted to investigate whether we find an association between heat and exposure and stroke. We searched the Mount Sinai electronic health records data, and we found about 5,000 stroke cases that were admitted to Mount Sinai. And we indeed found that heat exposure was associated with higher risk of developing stroke. For example, the odds of ischemic stroke was about 40% higher among those who were exposed to 30 degrees Celsius compared to those exposed to minus 10 degrees Celsius. And then finally, I wanted to end with a more positive note and talk about a beneficial environmental exposure when we talk about cardiovascular health. We know that greenness is very good for your health. It has beneficial effects on different diseases. We don't know exactly why. It can be because of the opportunity for better habits, for have a place to run, better opportunities for physical activity. It can be related to environmental exposure reduction. The trees help to provide better air quality and lower temperatures because of the shade. Maybe it's the reduced stress. You go to the park, you have opportunities to meet up with people and family, get a sense of community and social support. And there's also a theory, the theory of biodiversity, which says that different types of trees and animals can promote beneficial bacteria exposure. So the bottom line is we don't know why, but it is good for you. So there's no harm, I guess, in spending time in green and nicer areas. Just to summarize, I'll end up by saying that when we consider our risk of stroke, we need to remember that beyond these traditional behavioral and clinical risk factors, there's also this environmental piece with all the exposures that we're exposed to throughout our life that shape our cardiovascular risk on the long run. And I wanted to mention all my students and colleagues who contributed to the studies that I presented here, and of course, all the funders who funded these studies. And thank you so much for listening. I'll take questions.
Actually, we're going to move briefly to, before we get into Q&A, we are going to hear a little bit from Dr. Nabeel. So thank you so much, Dr. Yitshak-Sade. And I want to let the audience know to put any questions in the Q&A, and we will get to as many as we can. Dr. Nabeel, can you share your perspective for a few minutes as a clinician on this research and what opportunities you are seeing in clinical care and prevention?
Thank you, Ellen, and thank you, Maayan. Really interesting and amazing conversations. First of all, I do want to acknowledge that the environmental realm and its impact on health it's a nuance, and our understanding of these two entities have been evolving. So thank you for contributing to this understanding even further. Environmental factors and stroke risks have been in the literature for a long time, but now we have the ability to look at the exposures and stroke in one sentence and sort of looking at it clinically. You're reminded that there are other factors contributing to stroke that we completely ignore as a clinician. So as a clinician, we usually focus on major risk factors like hypertension, diabetes, smoking, hyperlipidemia. And we know from the literature that these factors are very, very important. And environmental factors are historically underappreciated, despite their potential impact on health. So I'm thrilled to see that there's renewed and even a more focused understanding of these factors contributing to our stroke risk. There's subtle impacts, but they are profound impacts. Like Maayan mentioned about green spaces. There's now emerging data supporting that notion that incorporating green spaces in urban planning and design can really impact your stroke risk. We also have a lot to learn about ethnicity, age-related impact, vulnerable populations. For example, taking air pollution and looking at this specific threat to public health, and particularly stroke incidence in vulnerable population, especially elderly who are more impacted by pollution as well as the stroke risks, and people with comorbidity and conditions. I think it's important to realize this link, and we need to incorporate it into our clinical conversations with our patients. And that's the step that's the hardest part, right? You need to translate those findings that researchers are doing and put it together in a way that patient understands their risks and how can we modify them? How can we change those risks? There's lots of things to consider: socioeconomic status, age, as I mentioned, demographic factors, where the person has been living, how you're exposed to it. I can remind you that we just experienced wildfires, and it's happening right now in California, with high wind gusts. There is impact on human health with these events, and our understanding of these events are very limited. So I've started to ask my patients, or having conversations with them about where they live, how their health is impacted by environment. And these are not easy questions, certainly for both of us, for patients and for clinicians, to ask these in our busy practice where we are tackling a number of different issues. But I think it's an important step that we should take to understand the impact of pollution, PM 2.5, risks on stroke. These relationships are fundamentally changing our understanding of stroke evolution as well, and it can lead to different therapies or therapeutics that can help us not only minimize or mitigate the risk of stroke, but also prevent the risk of stroke in people. So much to learn, for sure. So thank you for bringing this up. I'm hoping that with this collaboration between scientists and a clinician, we can continue to have conversations that we can add to our understanding within clinical practice. How can we modify risk for patients that we see? These are complex relationships. The environmental factors, individual health, social determinants of health is involved in it. But every time I gain a deeper understanding, deeper knowledge from population-based studies, and then applying it at the individual level. So I'm all tuned to look at these new frontiers and see how we can bring this on the forefront at the clinical level. There is so many progress that we can make in minimizing the stroke risk in our patients. Thanks.
Great, thank you for that. Yeah, I assume with obviously the wildfires are an obvious example, and hopefully, we'll get to a point where you can tell people how to mitigate some of that, run air purifiers, whatever. I mean, inside even. I'm sure that it infiltrates, everywhere, not just if you happen to be walking in an area where you're literally inhaling smoke and, that kind of thing. It's
in California right now, people have lost homes. Yesterday's news is there's a severe devastation. A fire has been fueled by Santa Ana winds in California, and that's burning faster than they can put out. And that has an impact that goes beyond one's health. You're mentally stressed. You have lost your home. You deal with comorbidities. You're of certain age. So a number of factors that can contribute to this immense sort of a change in your health. And then the pollution that comes with wildfires is something to understand. And we, to be honest with you, as clinicians, we still have a very limited understanding of how it impacts the stroke risk at this point.
Makes sense. You mentioned something a few minutes ago about ethnicity, and there is a question that someone has about how the risks vary, or really, the risk of both stroke and of death, how that varies across racial and ethnic lines, if you have that.
Yes, so I can answer that. So in many of our studies, we try to find populations that are more vulnerable to air pollution effects and also exposed to higher levels of exposure. In the US, we find that ethnic and racial minorities and lower socioeconomic groups are exposed to higher levels of air pollution exposure. And they also experience more severe air pollution effects when it comes to cardiovascular disease and mortality. And this is after you account for all these traditional risk factors. So it's not because this population has a different set of cardiovascular risks that makes them more vulnerable. There are other reasons for these associations and reasons which we are still investigating, but one of the reasons is these higher levels of exposure in these populations.
Got it. Another question is whether there are any known differences in how air pollution and heat affect the risk of different types of stroke.
Yes, so the most consistent associations are with ischemic stroke, and we often find significantly increased risks for ischemic stroke associated with air pollution. When it comes to temperature, some studies find hotter temperatures to be a risk factor for stroke, but others find colder temperatures to be associated with higher risk for stroke. So, and some find both, that these extreme non-optimal temperatures for either direction are not good for you when it comes to stroke risk. So it's inconclusive. When it comes to hemorrhagic stroke, maybe because there are not as many cases, it's very hard to find consistent associations. Most studies found no association with air pollution or temperature. Some did find, and there are mixed results. So it's less clear, the association with hemorrhagic stroke.
Okay. Also, are there ways that people can minimize the risk of stroke associated with environmental exposure?
Yes. So I think that when it comes to environmental exposure, it may be very hard to control the outdoor sources. If we take air pollution, for example, it's very hard to control air pollution sources, right? You have almost no control over industrial or traffic air pollution that you're exposed to, but you do have control over your indoor environment. And you can try and do your best to minimize these indoor air pollution sources that you're exposed to. For example, if you're cooking and you have a gas stove in your house, you can make sure to open a window when you're cooking. Or use the proper ventilation. Or if you go for a run, you can try and choose greener environments away from traffic, so you won't inhale all these particles while you exercise. You can make sure to vacuum your rugs regularly so it won't accumulate a lot of dust. I think the most important thing is to be mindful of these exposures. And then there are very easy changes in your routine that you can make that will reduce your exposure, and you'll gain a lot of benefit in the long run.
Okay, yeah, that's really interesting. Another question that has come up is whether there are data on environmental factors in strokes in children.
Actually, I don't know the answer to this one. It's so rare in children that we mostly investigate this outcome in adults. We do have one study where we looked at not children, but young adults compared to older adults. And in this study, it was conducted in Israel. We indeed found stronger association with air pollution among young adults aged 45 to 55. And the effect was stronger than older adults, which shows that not always the older you are, the more vulnerable you are to air pollution. Sometimes it's the other way around.
Okay. Also, another question that has come in, and I wondered this myself. Do you have any insights on the recent implementation of congestion pricing in New York City and which way that sort of cuts?
Ismail, you want to take this one?
So there's a lot of people have different views on congestion prices. I think I need to see long-term data to really see the impact of what New York City is doing. Apparently, it's one of the few cities, or at least only city right now in the world, that has implemented congestion pricing. Even though it has impact in terms of reducing or changing the behavior of population, but we really need to see if it really translates into reduction of pollution levels, and I think that's where the rubber meets the road. I'm hopeful that if that is the case going forward, we see reduction of PM 2.5 in New York City. When Maayan was talking about running not next to the traffic, I wonder people living in New York City how they can do this, except for coming to Central Park, right? We have traffic all around us. We have to do better with city design. I think that's where the focus needs to be. I'm not sure that the fixing or one or two things or putting congestion pricing will solve the issue, but we have to rethink how we build the cities, how we use the cities, how we can have more greener spaces in the cities. We have modes of transportation that is multimodal, not only like what we're focused on, but multimodal kind of transport systems should be available in the city for people to commute and to work around it. So it has impact, but let's see if it really changes the pollutants in the air. And I think that's where I will be convinced that something has been done right.
Interesting. Someone asks if you could speak a little bit more about potential interventions to reduce fine particulate exposures. I mean, you touched on this before, but things like masks, or is there anything else that you recommend?
So I think a lot of this is on a higher level, right? Regulation. If we really want to lower exposure, we need to lower emissions from sources. And we have done a lot of work in recent years to show, like I mentioned in my presentation earlier, that setting 12 or 9 as the annual threshold is not enough. And of course, when these negotiations start talking about which number we should pick for the threshold, there's a lot of forces pulling in each direction. Environmental benefits and risks, economical consequences, health consequences. So a lot of our research is focused on showing that these higher exposure levels, these levels within the standard are still associated with higher risk. So when it comes to the point of review and the review of the literature, we'll be able to make a strong case saying it's still not enough, we need to do better. So this is maybe not on the individual person, but that's on us, researchers and clinicians to do. As an individual, you can try, like I mentioned before, and reduce your indoor exposure. Some, air filters can also be helpful in reducing particulate matter exposure in homes. Regarding masks, I don't know how feasible it is to be masked all the time. So when I'm asked about masks, I'm always not sure what to answer, because maybe it will reduce your exposure, but to what extent can you be with this all day? So I talking about myself, I try to focus on maybe other ways to reduce my exposure. But of course, if people are more vulnerable and they need masks for health reasons, then that's something else.
I can give you a quick example of like 2023 when the Canadian wildfires were happening in New York City. So the pollutant levels were much higher, much significant, much more concentrated. And I think at that time, masking, like individual masking, might be a good way to move forward. People with vulnerabilities, particularly asthma, COPD, or other conditions, they can stay at home indoors using air filtration systems, or if they need to go out, they can use certain masks, particularly N95 masks, might be more beneficial to use for individual risk reduction. But the answers are, of course, not in personal protective equipment. It has to be in engineering controls, policy decisions that can really minimize and change the risks that we are experiencing.
Sure. Another question that came in regarding heat. Can you comment on the importance of tree canopy development as a community intervention?
Sure. So one of the team members in my team is very interested in greenness. And he's always, trying to educate us on the differences of different greenness measures and how these can be translated into health. And from research in recent years, they know that not all greenness is the same. And the effects that you get from grass is not the same as the effect that you get from trees. And there is a lot of benefit that you can get from planting trees, right? The shade, other mechanisms that I mentioned that you might not know how, but it works. The other end is that it comes with a lot of pollen, and sometimes it increases allergy as well. So right now, there's research that tries to figure out what is the right way to go to try and solve one issue, but not cause another issue.
Right, understood. What do you see as some of the long-term consequences of environmental exposures, beyond some of the immediate kinds of, well, not that stroke is an immediate response per se, but do you see other kind of long-term consequences of these similar exposures?
Yes, it's a very important question. And it's important to know that environmental exposures like air pollution can have long-term effects beyond these short-term effects. And if we take stroke, for example, and air pollution, then these chronic long-term exposure can contribute to the development and worsening of the disease. But then these short-term exposures can trigger events and cause, rupture of plaques and cause heart attacks or strokes. So there's always this combination of the short-term effect and the long-term effect. So if you were exposed to an extreme air pollution effect, like the smoke that we got from the wildfires a few months back, beyond these few days where you feel uncomfortable, there may be long-term consequences of these exposure in terms of how it affects the body, the circulatory system, and your vulnerability maybe of developing other diseases later on.
So is there any way to sort of test for those things? In other words, let's say, you're aware of certain exposure, over a period of time. It could be, wildfire or something like that. I don't know. I'm just not familiar with, what kind of testing someone might do if they were concerned then about a particular exposure and, testing their cardiovascular or their, stroke risk, that kind of thing, just out of curiosity.
Sure. I can respond to part of that question. And going back into the long-term impact of environmental exposures, I think the good, really tangible example is World Trade Center responders who have been impacted almost 23 years to the day by the impact of this horrific event. And there was, if you remember, this dust of cloud that they were engulfed in, and most of the symptoms were respiratory, which we see in wildfires. Some of the symptoms were reflux related, and they also impacted, the lungs were impacted, where they inhaled a lot of smoke, dust, and soot after the event. And we have followed them longitudinally for a long period of time, and we see a change in their lung functions. We sometimes see the change in their respiratory symptoms. Some have been more chronically, so some of the symptoms are associated with obstructive sleep apnea symptoms as well. So there's a lot of long-term impact of these exposures that we see. And ultimately, we have also seen inflammatory conditions like sarcoid in this population, as well as we are seeing now cancers emerging with the latency. Again, the World Trade Center exposure is an anomaly. It was a big event that occurred. But as you've witnessed around the country, we have a lot of events that's happening, from pollution to everything. And we need to be cognizant of how to really start to document the exposure events. And most people are pretty good about this, because if you're talking about the exposure to the wildfires, they will tell you the story about what happened, how they were impacted or engulfed. And then that might be our first step to understand the exposure in our patient population. And then we can do subsequent tests. We can do pulmonary function tests, which could be done on multiple years to see if there's a decline in pulmonary function test. We also can see low-dose CT scans to see if there's changes in the lung that's occurring, like interstitial lung disease or fibrosis of the lung. We can also look at the ear, nose, throat tract by nasal endoscopies to look at if there's any change from the environment that happens. And then the cardiovascular risk, as Maayan said, there are multiple tests that we already do. We have a stress test to understand cardiac fitness. We have cholesterol checks and other things. So these are other additional tangible pieces that we can do right now to stratify the risk. And on top of it, we can understand what the exposure was and see what the long-term risks might look at. But these answers are not really definitive, because we still have a lot to learn about the risk of PM 2.5 and its impact, its direct impact on cardiovascular health. So that's an evolving science.
Okay, so we're just about out of time, but if either of you or both of you would like to end with sort of one comment that's forward-looking, and what you see, maybe some optimistic predictions for the future as to whether policy or research-oriented, et cetera. If you each had sort of one sentence, and that would be great, and then we'll wrap up.
Sure. So the good news is that we are making a change. Policy is shifting, like we see a couple of years ago, and I'm sure we can continue and do our research and contribute even more to promote health in the US and globally.
I think I'll tell directly to the patients, ask the questions with your healthcare, like put them in a place where they're trying to seek answers for you. Like, climate affects all of us. It has tangible effects on our health. So we should demand that from our clinicians, our educators, everybody else to get the answers that we're looking for, and how these events are impacting our health is the most important point that we want to make. I think that will help all of us.
I think that's great advice. Okay, I would like to thank our panelists and everyone who joined today. Our institute is not just doing research, we're working with parents, communities, and leaders to build healthier communities. And I encourage all of you to stay connected. And I really, hope that you will consider supporting some of this critical work. Please fill out the evaluation form. There's a link in the chat. And please get in touch with us to get more involved if you would like to. Thank you again to everyone.